Hello, this is a quick video on the approach to the Simman station for Plab 2. And that is me. I'm Joshua. I'm just here to share with you my experience for Plab 2. I did it a few years ago, and this is how I approach the Simman station. So I'll do in this video take you through what a Simman is, or Sim woman, the ABCD approach, and the ice bar. So a Simman is, oh, before I get to that, I put in this quote here. I love some useless quotes just for a break and introduction. I love fake people provided they're mannequins. So let's get to business. A seaman is derived from two words, simulated man. So it's usually an adult-sized human patient simulator. It's designed to mimic a real patient, so it will have some signs and symptoms that a patient will have, and it's used to educate medical students, and in this case also to examine doctors going to the plab too. So it may have a heartbeat, it may have a wheeze, it may have a pale leg, or that kind of thing. So what you'll find in an exam setting is usually a mannequin that looks uh, like what you're seeing on your screen, and then on one side of the bed will be the examiner, and then around the bed you will have probably a cardiac monitor and some other things, IV fluids. It could be attached to a BP machine, some pulse oximeter, and all those things. So this is what similar to this, perhaps not with all this with the same kind of things connected to it, but the mannequin will fairly look similar to what you have here. So it's just like any other mannequin, but it has the ability to simulate patient symptoms. The approach to a cement station. So again, a useless quote for an introduction to this next section. Not actually, this is not a useless quote. This is a very useful one. This guy called Jack Pepper said, "I tell a student that the most important class you can take is technique. A great chef is first a great technician. If you're a jeweler or a surgeon or a cook, you have to know the trade in your hand. You have to learn the process, and you learn it through endless repetition until it belongs to you." I think this is a very necessary quote for Plab 2 and for Simman stations, and actually the daily real life clerkship of a doctor, even in clinical situations. You must have your own technique, your own approach, and you master it by doing it over and over again until you get it, until it becomes your own. Just by doing it repeatedly, by making it your own way of doing things. So, how do you approach a Siemens station? Now, one thing you must remember is that though this is a mannequin, you will be expected to interact with it as if you're interacting with a real human being. Talk to it, call it by its name, listen to it, palpate it, auscultate it, percuss it, inspect it as you will do a real patient. The examiner is with you in the room, and they're giving you marks, and they're looking at your interaction with this mannequin. Feel its emotions and relate to them. Deal with it as a real human being. So in this Simon station, I think for me, the approach I use was the ABCD approach, which if you've done any emergency medicine, you probably are aware of. So A stands for airway, B for breathing, C for circulation, D for disability, and E for everything else. I'm just going to tell you how to apply this approach in a Simon station in Plab 2. I believe if you stick to this approach, you will always get all the marks, or most of the marks you're supposed to get. You'll get the right diagnosis, and even if you miss out the right diagnosis, you will have done majority of the right things that you're supposed to do to make sure this patient, this seaman, this mannequin survives and doesn't die. If they die, you've obviously failed that station, because your task is to make sure you're a safe doctor who doesn't kill their patient, who doesn't let patients with reversible things die. So when you get into the room, actually before you get into the room, you will find the question card outside, read the question, then walk into the room. If once you walk into the room, if you have forgotten by any chance, maybe just because you are tired or you're panicked and you've forgotten some bits of the question, there's usually the question card again in the room. You can reread it. Then look at the patient surrounding. Do a quick scan of the patient surrounding. It may give you some hints and clues. There could be something running on the stands, some fluid, something that looks like blood or IV, I mean some catheter. The patient could be attached to something. There could be some drugs or some inhalers, things that could give you clues of what might be the problem. Of course, the question is the first thing that gives you the clues, the question you read. The second thing is the patient surrounding, even before you start talking to the patient. Remember the examiner is seated in the room. Introduce yourself now. Once you've done the quick scan, begin the session as you would with any real patient. Introduce yourself, confirm the patient details. So confirm their name, their date of birth, and then move on to asking the question about their presenting complaint. Now, remember, in a Simman station, you're not being primarily examined on history taking, so you shouldn't spend a lot of time gathering questions on history. This is an emergency, so you just want focused questions that will help you to manage this patient. And as you ask these questions, you're also looking around to make sure that your patient does not die while you're taking history. So it's more of an intervention station than a history taking station. You should be doing stuff. So having said that you should be doing stuff doesn't mean you shouldn't ask questions. You don't want to be doing things and probably just one question could have helped you to discover. For example, if you ask, do they have any allergies? And you discover they are allergic to something and the drug that they're allergic to is what is causing their problems. You didn't ask that, so regardless of what you do, if you've not stopped that infusion, they're still going to have problems. So ask very focused questions. Just ask the presenting complaints and a few silent things depending on the scenario. Again, sometimes it may not be possible to do all this. For example, if the patient has altered level of consciousness, maybe they're drowsy or maybe they are unconscious. So you have to act. You can't ask questions. But if they're conscious, don't waste too much time on questions. Ask important questions. They're presenting complaints when it started, maybe the medical history, if they have any allergies, and then crack on to start assessing them as you intervene. Because this question, the marks really are on your assessments and interventions. Not majority of the marks are not really on the questions you're going to ask. So once you've done your quick focused history, quickly move on to the ABCD. So this is the core of the station. Remember, everything you're doing, verbalize them loudly for the examiner to hear you. So throughout your assessment, tell the patient what you're going to do it, then verbalize your finding. Do not just ignore the patient. Talk to the patient. Or just say them as you. So, for example, let's say this is Mrs. Smith. Let's say, Mrs. Smith, I'm just going to examine your airway. And then you look at the mouth and say, I can see there's nothing. And now verbalize. I'm looking at their mouth and I can see nothing in their mouth. I'm listening to their breathing and I'm looking at the chest rise, all those things, and I can feel some whatever you're doing, just say it. I'm looking, or they're talking back to me, so I know their airway is patent. So we're going to take A, B, C, D separately, and I'll basically tell you how to do it. But remember, don't take so much up to this point. Don't spend too much time in history taking. Take history, but be very focused. The core of the station is assessing the patient and intervening. Number two, verbalize everything you're doing loudly. Number three, talk to the patient. In as much as the examiner is in the room, you'd rather even ignore the examiner in the first part of the not until the time you're handing over. The person you're most interested with is the patient. So talk to them as you would talk to a real patient. Don't just do things without talking to them. Tell them I'm going to expose your chest and I'm going to listen to your chest. Ask them if there's any pain as you do whatever you're doing. Everything verbalized. So let's go to airway. When you start with the airway, do as you talk. Examine the patient's airway. Look, listen, and feel. You look at the mouth if there's anything blocking them. Look for chest rise. Listen if there's any noisy breathing and that kind of thing. And you feel for any moisture. Of course, you probably wouldn't feel this in a mannequin, but it's good to just verbalize. If they're talking to you, you don't need to do all this. You just need to say, uh, my patient is talking to me, therefore, I know their airway is patent. So I'm going to move to B, the breathing part. The breathing part, examine the chest, inspect the chest for chest rise, palpate, percuss, and auscultate. Then, once you've done that, look at the monitor on the parameters related to breathing. Now, again, just to pause here, there is no, you can look at the monitor first before you examine, whichever way you want to do it. There's no hard and fast rule, but I prefer you examine first, then you look at the monitor. Parameters related to breathing on the monitor will be the saturations of oxygen and the respiratory rates, if at all they are in the monitor. Then verbalize your exam finding. Again, I will emphasize do as you talk. So you can say, I've examined the chest, there's equal chest rise, I've percussed, and the note is tympanic all through, or whichever way, if maybe I've had a dull note on the right lower zones, whichever way, and I've auscultated and I've had a wheeze, whatever your findings are. And looking at the monitor, this patient has an oxygen saturation of 88%. And and then because you've seen these problems, the next thing is you want to intervene. If there's a problem, always remember they must intervene. So you say you verbalize the intervention because the oxygen saturations are low, 88% or whatever percentage you saw on this monitor. I'm going to put a non-rebreath mask on this patient and start him on 15 liters of oxygen per minute, high flow, 15 liters per minute of oxygen. I'm also going to order for a blood gas. Those are the interventions related to breathing. Once you've done that, normally if you have said the correct interventions, the monitor will change in response to intervention. If you've done the correct things, the saturations will improve. If you started the oxygen and it was 85, it will go to 94, 95, or 100. So that is what, if you probably they were having a wheeze and you say you're going to start some nebulizers and you do that, subbutamol nebs, and you do it, you expect some change after your intervention. So check for those changes also once you've verbalized them and verbalize the response to your change. So say after starting them with oxygen, normally when you've started the oxygen, maybe the examiner will tell you pick the mask and you're going to pick the appropriate mask. So you should know what the mask looks like. If it's a ventilator, I mean a nebulizer that you want to start the patient on, they'll tell you to pick the correct thing and put it on the patient. So you should also have an idea of, you're not going to do set up everything, but those masks are usually just by your side there. So you'll pick the non-rebreather mask and put it on the patient. And if you've done the right thing, look back at the monitor and say, I can now see the saturations have improved and the respiratory rate is probably also normalizing. Then ask the patient if they feel any better before you move to the next point. Remember, do not ignore your patient. The next is C, circulation. So examine the circulation. Inspection usually will do cyanosis if there's any cyanosis of bleeding. Normally, cyanosis mainly is actually a breathing problem, but probably if there's any bleeding anywhere, you will want to expect that. Palpate, palpate for cap refill peripherally and centrally, if the peripherals are warm or cold, the pulse, the weight, the volume, all those things are palpation. Then auscultate your patients, the heart sounds. Again, look at the monitor for the parameters related to circulation, and these usually are the pulse rate, the blood pressure, and the ECG trace. So you could also verbalize your exam findings. Say what you found in your examination as you are doing it. So as I'm auscultating, just say, for example, the heart sound normal. Do it as you verbalize as you do. Uh, it's a normal rhythm. It sounds normal. Probably I've had a mama, or it sounds very fast. And then you look at the monitor and you say, I can see the trace. There's a sinus tachycardia, or probably it's an AFib, whichever trace is there. The BP is normal or low, the pulse rate normal, high or low, whatever findings, verbalize them as you see them. Once if there's any problem, again, verbalize the problem and the intervention you're going to take. So for example, you say the blood pressure, I've seen that the blood pressure is 90 over, or probably 89 over 50. It's low. So you're going to put in two large bore IV cannulas, and while taking the cannulas, putting in cannulas in circulation, ensure you also mention that you're going to take the blood as you put in the cannula. It is good to mention what bloods you're going to take. So the common bloods usually are, we had mentioned the blood gases, blood glucose, the BMs, full blood count, UNDs, LFTs, blood culture. And then you say because the BP is low, you're also going to start them on IV fluids, and you can mention normal saline 500 ml more or less, or whichever fluid that you think is appropriate depending on the scenario. Once you've intervened, check if the intervention has improved. Has the BP increased after intervention? Just check. Sometimes it may not have, but before you move to the next point, after you've intervened, ask the patient if they feel any better. And remember, don't forget the patient. So even as you put in the cannula, tell the patient we are going to fix this. We're going to put this needle into your hands, and it's going to help us to give you medication, and we're also going to take blood tests. Continue talking to the patient as you do your stuff. Then move to D for disability. So comment on the level of consciousness of the patient, the GCS, if you're able to say that. If you're not very quick in calculating it, do not fixate yourself on getting a correct GCS figure. You can just say the patient is alert, or you might as well just say the patient is unconscious or drowsy. It's good enough. So comment on that, and then ask what their blood sugars are. If there's a problem, again, verbalize what the problem is and intervene. Verbalize your intervention. Check for any changes after you've intervened, and ask the patient if they feel any better. So it's the same routine. Assess, verbalize your assessments as you do them. If you find a problem, verbalize the problem and intervene. Verbalize the intervention. Check if there's any change after your intervention, and verbalize if there's that change too. And then ask the patient if they feel any better after your intervention. Of course, if there's no problem, just move on swiftly to the next letter, E, which is everything else. So once you've done A, B, C, D, everything else. So now you can say, now I'd like to do a complete examination, head to toe examination, and mention the things you'll be looking at. I'll probably want to look at the abdomen. If you suspected there's a problem in the abdomen, for example, if it's a post-op patient, you'd like to look at the surgical scar for any bleeding. Or if you think it's a gynecological bleed, you like to do a proper vaginal exam, and all that. Then once you've finished, summarize your findings to the examiner using the iceberg approach. So this is where we come to the last part. So after you've assessed, you may be required to summarize your findings to the examiner. Normally, the examiner will ask you to summarize your findings. So iceberg is a good approach. So whether or not the question tells you to summarize, it is a good practice to assume and always prepare yourself to summarize your findings. So once you've done everything, A, B, C, D, E, now summarize. So whether or not it has been mentioned, just prepare to summarize. But what does that mean? Identity. So for example, you can say, I have assessed Mr. Adam Smith, who is a 35-year-old man. So male. So that's the identity, their name, their age, sex. Who came in with chest pain, presenting complaint. That's the situation. Acute chest pain or whatever. Who had undergone surgery and presented with altered level of consciousness 2 hours post-op. Whatever the question said of the presenting complaint, then the background. What is the history of the presenting complaint plus relevant medical history? So let's say, as we've said already, background post-op. So the patient had had this kind of surgery. They don't have any relevant medical history, or they have whatever diseases they have, plus or minus allergies. Known to maybe he had a what an acute altered change of level of consciousness in the ward. Patient is known to be penicillin allergic and had been started on amoxicillin for whatever. So that's the background, the medical history and allergies. What were your significant exam findings? So you can say assessment. On assessment, this patient had, so you said just think of the problems you found in your ABCD. So if there was nothing in the A, you don't need to mention it, or you could mention it just to be systematic. You can say this patient had a patent airway with low saturations and tachycardic, hypotensive and tachycardic, and had an altered level of consciousness. Or we, and then the interventions you did, we started him on oxygen, IV fluids, or we stopped the whatever the antibiotics and gave them some EpiPen, adrenaline injection, whatever interventions you did, say them in the assessment bit. It is good to quickly summarize your ABCD in the assessment and the interventions you did. And then recommendations. Now, this is your differential diagnosis and what you recommend for further management. So, I think this patient had an anaphylactic reaction to penicillin, or I think this patient had a pulmonary embolism. And I will suggest X, Y, and Z. My plan is to, number one, for further investigations, such as what a CT PA, CTPA, whatever it is. If what else would you think of? I mean, depending on the scenarios, the scenarios are different. If it's somebody who's bleeding post-op or who has altered uh, whatever post-op, you'll say, I would recommend that you do a full vaginal exam under anesthesia to check if there's any bleeding, and also do a CTPA to rule out pulmonary embolism, etc. And I'll also discuss with my seniors to review this patient for possible, uh, maybe possible what, possible, you actually don't need to say what you're going to do, but just think of it. I like to discuss with my seniors. Always mention that, because in Plab 2 you're being assessed at the level of a foundation year doctor. So always mention that you're also going to discuss with your seniors. So just mention your differential diagnosis. You don't need to have a long list. Just mention the first one and the second one. If somebody's coming with chest pain, probably just a myocardial infarction or pulmonary embolism, and then mention some two other investigations you'd like to recommend and some further management. Refer to cardiology or to pulmonology, I mean the respiratory guys or the surgeons, and also discuss with my senior. Always mention that you're going to discuss with your seniors for any Plab 2 sessions where you're managing a patient, because you're a foundation year doctor, so you're You can't make independent decisions. You're not, you can, well, you can actually make independent decisions, but they have to be vetted by your seniors. Let me say so. Yeah. So that's it. And thank you for listening to me. Uh, See you next time. Bye.